So hi everybody, my name is Manuel Maia. I'm a medical oncologist from Brazil. Right now I'm doing a research fellowship at City of Hope in California. And today I would like to discuss some results of one of our posters that are being presented here in San Francisco at ASCO GU. One poster that I would like to discuss is the relationship between tumor mutational burden and response to immunotherapies in kidney cancer. We know that in other disease sites such as melanoma, lung cancer, and bladder cancer, tumor mutational burden correlates with response to immunotherapy. However, in kidney cancer, it is still not clear what it makes a difference in this setting. Therefore, we aim to collect information from those patients who had undergone genomic profiling at our institution, and we calculated the tumor mutational burden of these patients, taking into account the cumulative incidence of VUS and non-VUS mutations. We stratified patients into high or low mutational burden according to the number of mutations, and we also stratified patients according to the best response to immunotherapy. So we divided patients into clinical benefit patients and non-clinical benefit. Clinical benefit patients comprise those who had complete or partial response or stable disease, and non-clinical benefit, those who had progressive disease as the best response. So we had a total of 31 patients to analyze, and the majority of patients had clear cell histology as expected. Majority of patients used nivolumab as the immunotherapy compound, and the majority of patients were receiving IO after second-line therapy. So when we stratified patients into clinical benefit and non-clinical benefit, the median number of mutations among these two groups was similar, 11 versus 10 mutations, which of course was not significantly different. After that, we also analyzed the duration of therapy with immunotherapy among patients with high and low mutational burden, and these two groups with high and low mutational burden did not differ in terms of total duration of immunotherapy. So it was, again, not statistically significant. So as a conclusion, our results corroborate the findings from previous studies that failed to show an association of tumor mutational burden with benefit from immunotherapies in kidney cancer. And it's still unclear why it's not seen, since kidney cancer is a known disease that it's known for being very responsive to immunotherapy. So one of the possibilities is that, in fact, when we analyze our data, we are taking into account the number of non-synonymous mutation. And if you take into account only non-synonymous mutation, as most studies have shown, kidney cancer sits right in the middle of total number of mutations compared to other disease sites. So this may not actually explain why kidney cancer responds to immunotherapy so well. And as published last year in Lancet Oncology, one paper showed that, in fact, the most important is not the total number of non-synonymous mutations, but rather the proportion of frame shift indels, which are one type of mutation that seems to be more immunogenic. And when you take this into account, kidney cancer seems to have the highest mutational burden. So in fact, that may be the way forward when we are trying to explain mutational burden analysis in response to immunotherapies in kidney cancer. Thank you very much.